From the 36th annual meeting of the APACRS in beautiful Chengdu, China, I'm Josh Young. I'm here today with Pannet Panputipang. Pannet, you gave really a super interesting talk. I mean, there's a lot that I've learned at this meeting that I'm going to bring home to my practice, but none more important than yours. So I, like all of us who do cataract surgery, I have patients with intumescent white lenses. They're always frightening, always concerned that I'm going to get an Argentinian Flag Sign. I also spend a great deal of time teaching cataract surgery, teaching residents. It's even more of a concern with them because it's not my hands, And what the traditional teaching has been, and what my teaching has been, is that we have to really pressurize the anterior chamber with viscoelastic in order to equalize pressure on both sides of the capsule so that there aren't vector forces that are going to tear the capsule out. And you have demonstrated that I'm doing everything exactly wrong. So please teach me.
Thank you. Thank you so much. You think about inside the lens, the pressure is very high. And then if you have the viscoelastic in the anterior chamber and you're trying to puncture for the initial capsulexis, the fluid inside with high pressure trying to escape but cannot because viscoelastic blocked. So the pressure inside will drive the tear to periphery. If you inject too much viscoelastic, the pressure will be even higher and higher, and the tear will run. So my conclusion now, is that don't use viscoelastic. Use the IA tip to pressurize with normal IOP. I set like 20 millimeter mercury, and then under balance of solution, I stab the capsule in the middle. The liquefied cortex can come out very rapid, so that's prevent the capsule from running to the periphery to create the Argentinian Flag Sign.
Okay, so I am going to restate in kind of my own terms to help me what you're saying here, because I want to make sure that I understand this properly because it's important. You're saying that the issue is that by having the viscoelastic in the AC, we're prolonging the equalization of pressure, the depressurization of the lens. We're making that depressurization longer, giving time for these forces to cause a tear out. And if instead we don't have any impediment to the evacuation of this liquid cortex from the lens, and we allow it to happen very rapidly, that there isn't going to be this sort of tear out. Now, if that were true, there are, and I'm not doubting you, I am. There are a couple things that I would expect. One of them is that if we do femtosecond laser, capsulotomy on a lens like this, that it's not going to tear out. Of course, we all know it does not tear out, but the conventional explanation has been that it's because we're getting such a large opening in the capsule at the same time that doesn't tear out. But if there's some way that we could pierce the anterior capsule before entering the eye and then pierce it in just one place, like from a IA Capsulotomy, the conventional teaching would be that it would tear out. Have there been any studies like this?
Yes, there's a report from Robert Pinto Coelho in 2007. He did one IA capsulotomy in the middle of the anterior capsule, 11 cases. The fluid come out without any single case of radialization of the AC anterior capsule. Yes.
That's mind-blowing. I mean, it really is. So your technique involves going in with the cystotomin with an IA for aspiration. Now, I know that there are a lot of techniques in which people advocate using the phaco probe to just pierce the lens and suck things up like that. That's not what you're saying. So the IA tip never crosses the anterior capsule. It's just there, and you're piercing it with the cystotome under low IOP, under an IOP setting of 20 with the phaco machine.
Yes.
What happens when you do that?
Yes. When we start the initial puncture, the fluid inside the lens will come out. And then
Rapidly, I bet.
Rapidly, yes. So the pressure inside the lens decreased very rapid. That's why there is no radialization of the tear. And then after that, we can inject the viscoelastic into the to inflate the anterior chamber before.
To doing the capsulorhexis.
Yeah, and then we can take the IA tip out and then continue with the rhexis using forceps.
Yeah. First of all, that the first time that you did that, it must have been so brave. It must have been so brave. So to be clear, the purpose of the IA there is twofold. It's number one, to make sure that as this lens evacuates suddenly that the IOP doesn't start going up, and number two, just to clear your view, right?
Yes, because when the milky material coming out, sometimes it obstruct the view.
Yeah.
And also you can aspirate that out, and also you can use the IA tip to gentle tap to
milk out more, yeah.
Yeah.
But
can
you're not actually going into the
No.
lens with the IA. That is absolutely fascinating. So, I mean, it doesn't. Look, these are famous last words. It doesn't sound difficult, right? I mean,
It's very simple,
to do this.
very easy.
So you're going through the normal steps at the start of cataract surgery, including trypan, okay?
Yes.
And then when we would normally put in visco, you're not. You are making the main wound under just saline.
Yeah.
And then you're going in with the IA and the cystotome.
Yeah. The sequence is that the side port, the main incision, and then inject the air bubble to stain the trypan blue. And then after that, you use the IA to wash out the dye.
The trypan blue, yeah.
Yeah, and then you just use the needle from the side port to stab in the middle of the lens to release the pressure.
So I've seen your videos, and it has rocked my world. You know, it's really something. I'm going to be thinking about this a long time, and you know, it's there. One of the things that I tell residents is just because something makes sense doesn't mean that it's true, right? So putting viscode in, pressurizing, all of that stuff made sense, but it's not a guarantee that it's true. And you've really demonstrated that if anything, that we're making things worse. It's incredible. I want to thank you for, first of all, having the bravery to even do this at the start, for bringing this really important topic to us, and for the generosity of the time that you've spent with me today.
Thank you very much.